This one too. If the individual lacks professionalism, skill, and confidence, the patient gets the same impression of laboratory personnel who test the specimen. If we are cold and inconsiderate, patients suspect that the lab is just as thoughtless with their blood and the quality of the results they report. More than likely, your laboratory does exceptional work, but can your patients tell that by the way you look and interact with them? Regardless of your profession or the department you work in, you project an image of what the laboratory is like. If your scrubs or lab coats are clean, then patients get the impression that the laboratory is too. Do you wear gloves when you draw blood? Then the patient gets the impression the laboratory processes samples carefully and with respect. Do you speak knowledgeably and considerately to the patient? Then patient says the laboratory must be staffed with knowledgeable and considerate people as well. Instilling confidence in your patients means acting and speaking professionally, calling them sir or ma'am instead of honey or sweetie. Being friendly is one thing, but make sure your patients feel respected and that you take your role in their health care seriously. Outpatient draw stations should be clean, organized, well lit, and protect patient privacy and confidentiality. Whether you're drawing blood in an inpatient setting or unconventional location, such as a patient's home or long-term care facility, a comfortable chair with armrests should be used to provide support. The chair should recline for pediatric patients or those who faint or have a history of fainting. Alternatively, a gurney or cot should be in the area. The chair should adjust to a comfortable height for the phlebotomist and provide the ergonomics that can prevent back injuries. A variety of supplies and a sharps disposal unit should be within reach. Identify outpatients by asking for their name, address, unique identification number, and or birth date. Have patients spell their last name where possible. Compare the information given with the information on the order, requisition, and identification band, if available. For inpatients, ask for and compare the same information. Any discrepancy should be resolved and corrected prior to drawing the patient.
All we really need to know about the importance of proper patient identification are these statistics based on the published literature. Over 7% of heart bracelets are either missing or they have erroneous information. One study found that up to 16% of their bracelets in one facility had incorrect information. 160,000 adverse patient events occur every year in the United States due to patient identification or sample errors in the laboratory. 11% of all transfusion-related deaths are caused by phlebotomists who incorrectly identified either the patients or the samples that they collected. So that's why we should never make any exceptions to our facility's patient identification protocol. We want to make sure we ask patients to state their name, their address, their unique identification number, their birthday, any one of those or a combination thereof. Let's have them also spell their last name as an added assurance. We just simply have to take these steps to make sure we're drawing the intended patient.
If the bracelet is not attached to the patient, do not draw the sample until the arm bracelet is attached. If you're not involved in their immediate care, have the patient identified by a caregiver or family member and then document the name of the verifier. If patients are unconscious, cognitively impaired, or have other communication barriers, seek confirmation from a caregiver or family member and document the name of the verifier. Any discrepancy should be resolved and corrected prior to sample collection. Avoid setting contaminated articles such as phlebotomy trays on patient contact surfaces. Patients use bedside trays to eat from and set personal items upon, including hearing aids, glasses, and other objects that can transport life-threatening infections. Some laboratory tests may require the patient be fasting, recumbent, or drawn at a specified time. Be aware of all test requirements and timed orders, and adhere to your facility's established protocol in order to provide meaningful results to the physician. Select the appropriate tubes for the test ordered. Keep in mind that underfilled tubes can yield inaccurate laboratory results. So, if you suspect a difficult or low-volume draw, Be sure to have smaller volume tubes within reach so that completely filled tubes can be submitted to the laboratory for testing. Next, perform a survey for available veins. The antecubital area is most commonly used for venipunctures because of the prominence of accessible veins. Other acceptable sites include the back of the hand and the thumb side of the wrist. Feet and ankle punctures should only be attempted with physician permission and according to facility policy. The CLSI standards prohibit draws to the front of the wrist where nerves and tendons are close to the surface. When drawing from the antecubital area, position the patient so that the arm is firmly supported. By extending the patient's arm so the elbow is locked, veins may come closer to the surface and are less likely to roll. Apply a clean tourniquet several inches above the antecubital area, creating a loop to allow a one-handed release. To avoid pinching the skin, apply the tourniquet over the patient's sleeve if possible. Perform a thorough survey of both arms unless prevented by injury, mastectomy, IV therapy, or other precluding condition. Discourage patients from pumping their fist. Such rapid muscle contraction has been shown to increase the levels of potassium and ionized calcium in blood samples drawn. Attempt to locate the 3 veins of the antecubital area acceptable for venipuncture by palpating the tissue. Veins feel round and resilient. Avoid slapping the patient to make the veins more pronounced. Not only might it affect certain blood levels, it's overly aggressive and unprofessional. Instead, lower the arm or use a warm compress not to exceed 42 degrees Celsius to locate hard-to-find veins if necessary. The median cephalic and median cubital veins, collectively referred to as median veins, generally run parallel or at a slight angle to the arm through the center of the antecubital area. The cephalic veins lie lateral or to the outside aspect of the antecubital. Punctures to either of these sets of veins are least likely to result in injury should the needle miss the vein and should be ruled out before drawing from the third choice, the basilic vein. The basilic vein lies on the medial or inside aspect of the antecubital area and is in close proximity to the brachial artery and to the median nerves. Because of the increased risk to these structures, those who consider this vein only after ruling out the median and cephalic veins of both arms reduce the risk of injury to its lowest possible degree. When the tourniquet is left on longer than 1 minute, the concentration of many analytes begins to change. As the blood pressure below the tourniquet increases, water and smaller compounds efflux from the capillaries into the tissue, altering the concentration of some constituents in the bloodstream. Those that are too large to pass through the vascular wall exist temporarily in higher concentrations, leading to collection-induced elevations in red blood cells, hemoglobin, hematocrit, platelets, albumin, potassium, cholesterol, calcium, and other analytes. The term for this effect is hemoconcentration. Therefore, if the vein cannot be located and accessed within 1 minute, release the tourniquet and allow the blood to pass through the arm for 2 minutes before reapplying it and performing the puncture. Depending on the test order, the size, location, and integrity of the vein, and the quantity of blood required, those who draw samples for testing have a wide variety of supplies and equipment from which to choose. Draws from pediatric patients, geriatric patients, vascular access devices, and a multitude of other variables and conditions require unique combinations of equipment and technique in order for the procedure to be successful. Selecting the wrong equipment can be the difference between a successful and an unsuccessful venipuncture. There are at least 3 systems for obtaining venous blood samples. Generally, draws to the antecubital area are performed using tube holders that allow tubes to be filled directly from the vein. Syringes with needles attached are used on smaller, more fragile veins when it is thought that the vacuum applied directly from a tube would collapse the vein. Finally, winged collection sets are used when larger quantities of blood are required. For example, when blood cultures are ordered along with other tests, or on difficult veins that require precise needle placement. Regardless of the system used, select smaller needles for fragile veins and to minimize discomfort. This is especially important with pediatric patients and others who are anxious about the procedure. Put on gloves and cleanse the site with an alcohol prep early. If the skin is excessively soiled, use a second pad. Wet alcohol stings the patient upon needle insertion and could hemolyze the red blood cells as the sample is obtained. Therefore, allow the alcohol to dry before performing the puncture. Do not blow on the site. If blood cultures are ordered, prep the site with iodine, chlorhexidine, or other stool antiseptic, allowing it to remain in contact with the skin for 30 seconds, or the duration established by facility policy or the antiseptic's manufacturer.
It's not good practice to repalpate the site. Once you have prepared the venipuncture area, it should never be entered into again for the purpose of palpating, because your gloves are not sterile. And as a result of that, you are actually contaminating the venipuncture site and increasing the risk for collecting the blood cultures contaminated on the skin organisms. So once again, palpation after the site's been prepared is unacceptable.
When using a tube holder assembly, hold the assembled device between your thumb and the tips of your first 3 fingers. This allows ample room to manipulate the tubes in and